Hello, my name is Lauren Lazar, and I am one of the Pediatric Gastroenterology Fellows here at Children's and UT Southwestern. I, along with my mentors, Dr. Meg Sate and Dr. Sharina Ramirez, are applying for the Fellow Research Scholar Award. Our project is entitled Utilizing Ultrasound Elastography or Magnetic Resonance Elastography to Improve the Diagnosis of Cystic Fibrosis-Associated Liver Disease. We'll start off by giving some background and significance about cystic fibrosis-associated liver disease. Cystic fibrosis is an extremely common autosomal recessive genetic disorder. A wide variety of genetic mutations cause abnormalities in the CFTR gene, causing dysfunction of the CFTR protein. This protein is a membrane conductance regulator that is pivotal in epithelial electrolyte transport. Lung disease is most commonly associated with CFTR dysfunction, but the liver is another organ that can be devastatingly affected. Hepatobiliary manifestations of CF can encompass a variety of presentations, including transient elevations in liver enzymes, neonatal cholestasis, hepatic steatosis, and cholelithiasis, among others, but the most devastating is focal biliary cirrhosis progressing to multilobular cirrhosis. Multilobular cirrhosis is the third leading cause of mortality in cystic fibrosis patients behind lung disease and complications of lung transplant. It is a largely subclinical disease with late diagnosis due to ineffective screening. I wanted to discuss the pathophysiology of disease. One of the reasons the screening algorithm does not detect CF-associated liver disease well is the fact that the pathophysiology of disease is still very poorly understood. What we know is that CFTR is expressed in the biliary tree and not in the hepatocytes. As a result, we theorize that defective or absent CFTR protein leads to abnormal chloride and bicarbonate transport and decreased bile flow with bile duct plugging. The plugging leads to accumulation of toxic bile acids and subsequent hepatocyte and cholangiocyte injury. Cellular injury induces an inflammatory cascade, ultimately leading to collagen deposition, placing the patient at risk for fibrosis and cirrhosis. We also know that modifier genes or the patient's specific CFTR mutation may impact the mechanism as well. Next, we will discuss current screening for disease. Given that CFTR is not expressed in the hepatocytes, it makes sense that transaminitis may not be a predominant finding in CF liver disease. However, the screening guidelines heavily rely on AST and ALT as markers of CF liver disease. Patients are screened annually. If there are moderate or gross abnormalities, they go on to further evaluation. Further evaluation may include liver ultrasounds or testing of liver function, including PTINR, ammonia, glucose, or albumin. They may also undergo evaluation for other liver disease that might explain the elevation in transaminases. This existing algorithm unfortunately falls short in early diagnosis. The biochemical test abnormalities do not correlate with fibrosis or cirrhosis. Traditional ultrasound may provide some indication of advanced disease, but is overall limited in its prognostication. There are some promising new screening modalities out there. There is AST to platelet ratio index, or APRI. This is validated in adult cirrhotic liver disease, particularly in the hepatitis C population, and there are some early studies in pediatric CF patients that appear promising. Some centers are looking at GGT as a marker for CF liver disease, and perhaps this is a better marker given CFTR's expression in the biliary tree. Elastography is a type of imaging. It can be done with MR and ultrasound. It measures velocity of shear waves propagating to the liver, and higher velocities indicate stiffer tissue. The advantage with these tests is that they are non-invasive and may be useful in patchy disease such as CF liver disease. Next, we'll focus on our statement of purpose, hypothesis, and aims. The purpose of the study is to show that early detection of CF liver disease will enable clinicians to provide meaningful interventions to reduce morbidity and mortality of disease. We hypothesize that use of elastography and screening algorithms will allow for earlier detection of CF-associated liver disease, subsequently decreasing morbidity and mortality of disease. Our primary aims are as follows. MR and ultrasound elastography modalities will detect liver disease earlier than lab work plus or minus traditional ultrasound. We do have some secondary aims. The study will compare MR elastography and ultrasound elastography in older children and may provide important data regarding which modality is better at detecting disease. The study will show that using APRI to risk stratify patients will be more effective in identifying high-risk patients and will show that the old algorithm using transaminases misses these high-risk patients. Next, we will look at study design and methods. Here I've outlined our screening algorithm for the study. We have 288 patients with cystic fibrosis in our center. Of those, 133 are ages 0 to 10 years and 125 are 11 to 18 years of age. Rather than using the old screening algorithm, I will use this diagram to stratify patients as high risk versus low risk using APRI. The cutoff for APRI will be 0.264. This number is based on a study published in Hepatology in 2015. The study showed that an APRI of greater than 0.264 demonstrated a sensitivity of 73% and a specificity of 70% in predicting CF liver disease. Once stratified as low risk, patients will undergo regular ultrasound alone. If classified as high risk, the patients 0 to 10 years will undergo traditional ultrasound and ultrasound elastography. For high-risk older children, traditional ultrasound will be performed alongside ultrasound elastography and MR elastography. MR elastography will only be used in older children, as MR requires specific breath-holding techniques that younger children are typically unable to perform. If children have significant stiffness on MR and/or ultrasound elastography, we will consider ultrasound elastography or MR elastography of the spleen to measure spleen stiffness as another marker of advanced liver disease. Next, we'll look at anticipated outcomes. We anticipate that elastography will provide early detection of fibrosis and/or cirrhosis. We believe that earlier knowledge of advanced disease will allow for improved nutrition management. Earlier diagnosis of portal hypertension may allow for consideration of primary or secondary prophylaxis of variceal disease. Early recognition of hepatopulmonary syndrome and portopulmonary hypertension may lead to earlier referral for shunt versus transplant. There are, of course, some potential pitfalls and limitations to our study. It is a limited study with a small sample size, as it's only a pilot study. The high risk versus low risk designations have not been validated in cystic fibrosis. MR elastography may also give us different information than the ultrasound elastography, making interpretation of results in the older patients slightly confusing. Additionally, the technical challenges of MR elastography in the younger patients is somewhat of a limitation. This concludes my presentation. Here you will find my references. I really appreciate your time, and I look forward to hearing back from the committee.